Welcome, everyone. I'm Dr. Kirsten Gustafson. I'm the medical lead of the Menopause and Midlife Health Program at BC Women's Hospital. Today, I'm presenting from the traditional, ancestral, and unceded territories of the Coast Salish people, including the Katzie, Kwantlen, and Semiahmoo First Nations. I would like to welcome all our presenters and guests from across the province.
Tonight's webinar is generously presented by the Pacific Blue Cross, prepared in collaboration with the BC Women's Hospital and Health Centre, the BC Women's Health Foundation, and the Women's Health Research Institute at BC Women's.
And this is the second in our series on the topic of menopause. Our first webinar, titled Menopause 101, can be found on the BC Women's website, and we will continue to present webinars every 2 months, covering all the most important topics in midlife health. For tonight's presentation, Menopause, Mood, and Brain, I'm honored to introduce our speaker, Dr. Lori Brotto. Dr. Brotto is the Executive Director of the Women's Health Research Institute. She's a renowned figure in the field of women's sexual health. As a professor in the University of UBC Department of Obstetrics and Gynecology, she also holds a Canada Research Chair focused on developing safe and accessible treatments for sexual concerns in women. She frequently appears in the media, on radio, and notable documentaries, including the Netflix presentation, Principles of Pleasure, and CBC Gem Network's The Big Sex Talk. She's a practicing clinical psychologist and author of the book, Better Sex Through Mindfulness. Joining Dr. Brotto for this presentation is Nicole Presley, Manager of Research and Knowledge Translation at the Women's Health Research Institute. Due to scheduling, tonight's webinar has been pre-recorded. As such, we are unable to answer your questions in real time. You're welcome to leave your questions in the chat, and we will aim to address them with a later response. We may use your questions as well to help guide future presentations. And so now, without further delay, please welcome our speaker, Dr. Lori Brotto.
Thank you so much, Dr. Gustafson. I'm truly delighted to be with you here tonight to share information on management of and the latest science on a critically important topic related to menopause. As mentioned, my name is Lori Brotto, and I'm a professor in the Department of Obstetrics and Gynecology at the University of British Columbia and Executive Director of the Women's Health Research Institute. In British Columbia alone, there are 875,000 women aged 40 to 65 who are in the age range of perimenopause and menopause. And to clarify our terms, what we mean by menopause and perimenopause, menopause represents a single day that occurs after 12 consecutive months of not having a period. And in North America, this tends to be at the age of 51 years old. Perimenopause is the period of time leading up to that single day of menopause, and it can last years, and in fact, up to 10 years. And the period of time from the single day of menopause to the rest of your life is called postmenopause. So with an average life expectancy in North America for females of about 84, this means that you might be spending at least 3 decades of your life as a postmenopausal person. So with that background, I would like to start by acknowledging that I'm coming to you today from the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations. This acknowledgement, gratitude, and respect extends to all the First Nations communities on whose traditional territories our research teams and our clinical partnerships builds relationship. As noted earlier, I would also like to extend thanks to our partners who have helped put this webinar series together. I want to thank our collaborators, BC Women's Hospital, BC Women's Health Foundation, and the Women's Health Research Institute. And this talk today is presented by Pacific Blue Cross. I also want to acknowledge that I do sit on a number of advisory boards, and these are advisory boards that service women in the domains of sexual health and midlife women, and I've written a few books on women's sexual health. Menopause impacts half the population, and much of the previous research has been centered around cisgendered women, which means those individuals who were assigned female at birth and they identify as women. But menopause is something that cisgender women, trans, non-binary, and other gender diverse peoples can experience. And so in today's presentation, when I refer to women, please know that this information relates to females of diverse genders as well. So moving to today's topic, you may be aware and have heard in the first webinar series that up to 80% of women experience bothersome symptoms in the perimenopause. And even though we tend to think about hot flashes and night sweats exclusively, there's actually up to 30 different symptoms that women can experience during this transition period and beyond. Symptoms of menopause can impact daily activities such as work, caregiving, and mental well-being, and those symptoms can often interact or impact one another, which is why we're having this conversation today, so that you know when to recognize symptoms and hopefully when to seek help. Despite how common these symptoms are, unfortunately, social stigma, lack of awareness, and education can lead women to sometimes feel unsupported during this life stage. And our hope during talks like this and the entire webinar series, is that you feel leaving empowered with new knowledge to combat some of these barriers. So in today's webinar, we're going to talk about 3 important aspects of women's health that are often impacted by menopause, and they are depression, anxiety, and sexual health. I'll be pausing after each section to address some questions that have been submitted in advance before moving on to the next topic. Our own research at the Women's Health Research Institute, carried out in 2024, highlighted that for these particular symptoms, women often don't see these as being symptoms of perimenopause and instead may ask themselves, am I going crazy? Menopause is as much about the brain as it is about the ovaries, so it's not surprising nor abnormal to have mood and mental health related symptoms arise with menopause, especially since the brain is full of estrogen receptors. And as estrogen declines, brain function and brain health can be impacted. And this includes its effect on mood, anxiety, and sexual health. As I cover the symptoms of depression, anxiety, and sexual health problems during this webinar, I hope that you'll be able to identify whether your own experience might warrant speaking to a healthcare provider and getting help to address these symptoms. Getting help is so important because none of these symptoms remain in isolation, but can affect so many different facets of your life and your quality of life. So here we go. So first of all, menopause is characterized by several stages, and I'll walk you through this figure that you see in front of you. During the menopause transition, women can experience lots of different symptoms that can interact or affect one another and impact their mental health and physical health. Some symptoms are more common during the early stages of the transition or perimenopause. And looking at this figure, you can see that vasomotor symptoms, or what we commonly refer to as hot flashes and night sweats, peak in the late perimenopause and in the early years of the postmenopause. On the other hand, the cognitive symptoms, things like brain fog, forgetting words, problems with attention, tend to peak earlier in the perimenopause, and the symptoms often decrease over time, which is good news. Depression follows a similar pattern in that depressive symptoms tend to peak right at the menopause and get better over time. Sexual problems, however, as reflected in the red line, increase gradually in perimenopause, but then can continue to worsen over time and well into the postmenopause. So with that, we're now going to consider these in more detail. Depression and anxiety are among the most disabling conditions worldwide. Mental illness affects more than 1 billion people, or about 16% of the world's population. 1 in every 5 North American adults suffers from depression. Women are 1.5 to 2 times more likely to be affected than men. Depressive symptoms are really quite prevalent during the perimenopause and the early postmenopause, and this may be due to what experts call the window of vulnerability, which is linked to certain female reproductive stages during those hormonal changes. Yet depression is often under-recognized and undertreated, and we recommend that all midlife women be screened or asked questions about their depressive symptoms during this period of time. There's been a lot of research trying to understand how brain changes during the perimenopause, and in particular with estrogen's effects on the brain, can affect depression and depressive symptoms. Psychological factors, things like empty nest syndrome, which is that feeling of perhaps being alone when children or others leave the house, increasing work stress, and also caring for parents and teens, as well as elderly parents, what we call the sandwich generation, can affect mood, depression, and your concentration, and then, of course, sleep as well. I mentioned earlier last year in 2024, the Women's Health Research Institute led a large provincial study of over 2,000 midlife women in an attempt to understand their experiences with menopause and their help-seeking behaviors. And I'm going to, through this webinar, include some of the statements that our participants in that survey shared with us. As this 55-year-old postmenopausal woman noted, she said, "I'm just not myself. I don't like who I am. I don't like who I've become." It's important to recognize that depression can show up differently in different women. And now we're going to look at what are some of those hallmark signs to look for. So depressive symptoms include things like low mood, decreased motivation for your typical daily activities, having reduced enjoyment from the things that usually give you joy in life, disrupted sleep, and these symptoms may last a few hours or, for the most, a full day. But in the case of a clinical depression, as you can see on the right-hand side, or what doctors call a major depressive disorder, the symptoms are more severe, there's more of them, and they tend to last for a longer period of time, often on the order of many weeks. Symptoms of a major depressive disorder include having a depressed or very sad mood, loss of motivation altogether, absent or reduced enjoyment, having changes in weight, either gaining weight or losing weight rapidly, insomnia, agitation, fatigue or low energy, guilt, decreased concentration, and occasionally even suicidal thoughts or thoughts that one would be better off not around. It's really important to note that in a major depressive disorder, the person also has very high levels of distress. So the symptoms create a lot of distress or bother or interference for them. And I want to share these two, contrast these for you, because while many women during the perimenopause might have depressive symptoms, only a much smaller segment of that group of women will meet criteria for what we call a major depressive disorder. In both cases, we would recommend that you talk to a qualified healthcare provider to determine what's the best evidence-based treatment for you. So you might be wondering, am I at risk of having depressive symptoms during the peri or postmenopause? And this has also been an area where there has been a lot of research. What we know is that the biggest risk factor seems to be if you have a history of a depressive episode or a depressed period of time at some point in your life. This means that a period of 2 weeks or more where you've had the symptoms I showed you on the previous slide and they persisted for weeks at a time, then that would put you at significantly higher risk of having depression during the perimenopause. In fact, women with a history of depression are 13 times more likely to have clinically significant depression in the perimenopause. Also, if you have a history of depressive symptoms or mood changes in the days leading up to your period, what we often call premenstrual syndrome or PMS, or if you had significant depression in the postpartum period after having a baby, this can also put you at higher risk of having depression during the perimenopause. These are examples of what we refer to as that window of vulnerability that I mentioned earlier. And it signals when those hormone changes might be putting you at more risk for those mood changes. Another risk factor is if you're having menopause symptoms overall. And in fact, the more menopause symptoms that you might have, the greater the risk of having depressive symptoms. A third major risk factor is having many stressors in your life in general. And this is where having anxiety, especially if there's lots of stressors and you're starting to feel anxious about those stressors, that over time can lead you to be more likely to have depression during the perimenopause. So knowing these risk factors would be very helpful for you to identify, am I someone who may be at risk of having depression during this stage of life? But there is good news, and that is those women who have access to menopause-related information, like what we're sharing today and in this webinar series, those women who have a more positive attitude towards aging seems to protect or buffer against some of those depressive symptoms. Maybe having information like this helps you identify symptoms in advance so that you can intervene early if needed. So even if you don't have access to treatment, the next best thing is getting good information like this and having a positive or optimistic outlook on aging. But what if those symptoms are more severe? Just having access to information may not be enough. So I want to recognize that not everyone might have access to these treatments. If you don't have a family doctor, it may be difficult to get access to some of the medications that are approved. Or if you cannot afford a mental health provider or a psychologist, then having some of the psychological treatments may be challenging. So what does the research and the guidelines tell us? First of all, antidepressants, as well as cognitive behavioral therapy, or CBT for short, as I'll refer to throughout this webinar, are considered first-line treatment according to the guidelines. Antidepressants are medications that act on the brain, and there is very solid evidence in favor of using these for depression that arises during menopause. There's also very solid evidence in favor of CBT, which is a psychological treatment that involves a combination of targeting problematic thoughts and beliefs, such as, I will never be able to cope, or I am so broken, and replacing these with more balanced thoughts that are more accurate. When we can change thoughts, the research tells us that this has a direct effect on our mood as well as on our body functioning or our physiology. And this is also why hot flashes get better as a result of CBT treatment. But the way that, by the way, there's also very strong evidence in favor of CBT as a treatment for insomnia during the menopause, which is another component that can contribute to low mood. As far as the research on menopause hormone therapy, or MHT for short, there's less evidence here, and the research tends to show that it may be useful for reducing symptoms in the perimenopausal women only, not in postmenopausal women. You should note that this is not part of the guidelines, though, and would be considered off-label. Mindfulness is a mind-body treatment that involves paying attention to the here and now and doing so non-judgmentally. It involves daily practice of mindfulness skills, and there's over 40 years of evidence to show that mindfulness can be very helpful for treating depression. There's less research that's been done on mindfulness specifically on depression in perimenopausal women, but the few studies that have been done show that it can be quite effective. The benefit of considering mindfulness is that it is quite accessible through various apps and therefore might be more available to you. You'll recall on an earlier slide that I mentioned that the strongest predictor of menopausal depression is a history of depression. Therefore, a preventative approach is usually the best one. If you have a history of depression or depression before your periods or in the postpartum, you might want to be proactive and work with your doctor or other healthcare provider to monitor your symptoms of depression before they become too significant. So now's a good time to take a pause, and I'll invite Nicole to share some of the questions that you submitted in advance.
Thanks so much, Dr. Brotto. Your last slide, you mentioned sleep, and I know that's a popular topic as well. So one of the first questions that we have here is related to that last slide that you had up with the different treatments. It had the first and the second line treatment. This participant is asking if you could expand on how effective is cognitive behavioral therapy, or CBT, as an alternative to hormone therapy as a way of countering mood swings or depression during menopause.
Yeah, great question. So, as I noted, the menopause guidelines actually list cognitive behavioral therapy, or CBT, as a first line treatment. By first line, what we mean is it's one of the first things that a healthcare provider should consider, and it's because there's been quite a lot of research that's tested it specifically in this population. And so, in brief, cognitive behavioral therapy is delivered by a qualified mental health provider, maybe a registered psychologist or clinical counselor. And typically it's done over 8 to 12 sessions, and those can be spaced out weekly or every second week, or maybe even every 3 or 4 weeks, depending on the woman's availability. And what the research shows us is that because women are actually learning skills when they're doing CBT treatment, they're quite motivated to keep practicing those skills in the long term. So even many, many months or even years after they finish treatment, they continue to use these skills. And so the benefits to their peri and postmenopausal depression continue on in the long term. And we contrast that, say, with a medication where the benefits of the medication tend to stop once the person stops the medication.
Wow. That's very interesting. Our second question is from a participant with a bit of a scenario here. They're interested in hearing about the connection between what we call brain fog and our motivation related to menopause symptoms. And in particular, this person's asking, what questions should we go to our doctor with, or how do you even bring this topic up with your doctor?
Yeah, it's so great that this was brought up. And although I'm not talking about brain fog during this webinar, we know that cognitive changes, so brain-related changes that impact things like ability to think clearly, concentration, word finding difficulties, are actually really, really common. And as I mentioned very briefly, it's very much related to our brain is full of estrogen receptors. So during the period of perimenopause, when estrogen levels are going up and going down, and some refer to this as a zone of chaos, when estrogen levels are kind of all over the place. And then during the postmenopause, when estrogen levels go down, that gives rise to a lot of these brain-related symptoms that women experience that are very, very common. And that can lead to feelings of sadness and even depressive symptoms in some women, where you might think to yourself, am I going crazy? What's wrong with me? Will I lose my job? Is this a sign of a dementia? And let me be clear that it is not, that these are very common cognitive changes again, and we understand the mechanisms that are happening. So how you bring this up with a healthcare provider, a family doctor, is we often recommend that women track their symptoms. Maybe they track the intensity of them. They track how often they're having, so that when they talk to their healthcare provider, they've got a really clear snapshot of, say, over the last month, when the symptoms were happening, what made them better, what made them worse, and that they have a very clear conversation about all of the different symptoms that they're having. So the best thing to do is become your own tracker. And there are apps that do this, but you can even just do this on pen and paper or in the notes function if you have that on your phone.
And I was going to ask the duration. Is a month enough? Would you recommend more time if they're able to track their symptoms for a few months at a time?
Yeah, so because perimenopause can last, years and even up to 10 years, I think tracking as much as possible for you is really helpful, and especially in the periods of time between your healthcare visits.
Mm-hmm. Okay. Thank you. I'm sure many folks look for kind of ways that they can manage their menopause symptoms within their day-to-day lives. This particular participant asked about whether exercise, diet, or social connection can significantly improve or affect depression during menopause.
Yeah, great question. So we know that in depression in general, so not during the peri or postmenopausal period, that actually exercise has a lot of very strong scientific evidence that it works. So exercise in general for depression is excellent. There's less research that's looked at exercise specifically as a way of managing mood symptoms in the perimenopause, but the few studies that have been done show positive benefits as well. We often recommend that as part of your foundation of health, that having exercise, good nutrition, reducing or eliminating alcohol and other substances, having good social interactions, those are all really important pillars of health. And those also should be things that a healthcare provider asks you about.
Thanks so much, Dr. Brotto.
Okay, so we're going to move on to our second topic for today, and that is anxiety. And what's important to know is that anxiety can occur with depression, but it can also occur on its own. And the menopause transition can be a period of increased risk for anxiety. So either having a brand new anxiety period of time, or if you're someone with a history of anxiety, the perimenopause can be a time where we see many more symptoms. And in the large studies, over half of perimenopausal women will report feeling anxiety. So why are women feeling anxious in this period of time? Menopause is associated with changes in the stress response system in our body and in our brain, something we call the hypothalamic pituitary adrenal axis, or HPA for short. And you may have heard about HPA in what you've read or on social media. So it's important that you understand what the HPA axis is. But essentially, it's the part of the brain that helps us cope during a stressor. And when the HPA axis is not functioning well, it can really impact our feelings of stress. So postmenopausal women who are not on menopause hormone therapy do have they do tend to have a greater response, the stress response hormone called cortisol, to stress, which can contribute to anxiety, and it can also contribute to memory problems. So what does anxiety in menopause look like? Different women experience it somewhat differently, but it can include irritability, nervousness or tension, being afraid, feeling like your heart is pounding out of your chest. And anxiety can be experienced regardless of whether you're experiencing those vasomotor symptoms of hot flashes and night sweats. In a very large study that has been done in the past called the Penn Ovarian Aging Study, the researchers tracked anxiety over time, and they also tracked hot flashes and found that certain parts of anxiety, so specifically chest pain, feelings of fatigue, and dizziness were found to be very much associated with hot flashes, regardless of the women's age, their stage of menopause, and regardless of whether they had depressive symptoms. In other words, having hot flashes can make you feel more anxious. Perhaps you're worrying about when the next hot flash will happen and if it will disrupt what's happening in your life. But also having more anxiety can trigger hot flashes. These affect each other in turn. It also suggests that treating hot flashes can reduce anxiety, and indeed, there's a lot of scientific evidence for this. There's something that researchers call the domino hypothesis, and what this means is that those vasomotor symptoms, hot flashes, night sweats, which are worse at night and can lead to disrupted sleep or waking up in the middle of the night multiple times, which can then affect your brain function and your anxiety. So you can tend to see how these different symptoms all impact one another. And it's also a good reminder of why we want to be managing all of these symptoms, not just one of them. In our study that I referred to earlier, the HER-BC study, one of our participants discussed how she experienced the link between anxiety and depression. And she said, "Your body's not working anymore. It's not the body you recognize. You have all these aches and pains you've never had. You don't know what it is. It just happens almost overnight. So there's a lot of trying to adjust and accustom. And then there's the anxiety and depression that come with it. Is it hormonal? Is it something more serious? Is it brain chemistry?" You get the point. You're so confused as to, well, what is this? And what do I do about it? Most women want to be informed about menopause and any issues that might come along with it. So psychoeducation and health education represent the structured presentation of information on health and disease. And education can happen in groups, such as a support group or education group. It can happen in community levels. It can also happen one-on-one with your healthcare provider or other qualified menopause health expert. And it includes sharing information, workshops, and providing a space where women can talk to one another about their symptoms. The goal is to provide knowledge that can help women have a greater understanding as well as an understanding of treatments. When we think about stress and stress management, women should, for example, receive education about the link between stress and anxiety and menopause symptoms, and they should have information about the specific treatments that they can apply to reduce stress. Studies have shown that after receiving an educational program about menopause, which included topics like stress and stress management, that this led to women having more accurate information, more realistic expectations about menopause, more positive attitudes about menopause, and less discomfort in their menopause symptoms. There's also a lot of evidence that targeting stress directly and daily hassles can be effective for managing anxiety during the perimenopause and menopause. So some stressors are very typical in the midlife, and we mentioned a few of them earlier. Changes in family dynamics with people perhaps leaving the house. There may be changes in your work status, and there may be changes in your leisure time or social interactions. Often women in this period of time are in what's called the sandwich generation. And this means that they're caring for both their own children as well as elderly parents at the same time. And this can lead to a lack of time for them, for women to have for themselves and to do the things that are important, both for their well-being, but also for their health. And those stressors can be targeted by time management, things like scheduling time in your schedule to ensure that these activities, which are very beneficial to your anxiety and mood, happen. Can also involve maybe some delegating and delegating to other people, partners, children, your community, as your resources allow for outsourcing certain things. We talked earlier about CBT and depression. Well, it turns out that CBT is also very helpful in managing anxiety. And it does so by identifying and modifying unhelpful beliefs and thoughts and expectations. And the goal is to identify and challenge those beliefs and change them to more realistic expectations for the future. Adapting attitudes towards menopause can reduce stress, and it has been shown to have a positive effect on helping women manage anxiety overall. And targeting the stress response system in your body directly also has a lot of evidence in favor for it. So you'll recall I mentioned mindfulness as a treatment for depression. Well, mindfulness exercises can also be used as a way to manage anxiety during the perimenopause. Many women often ask, what about menopause hormone therapy as a treatment for anxiety? And maybe they saw something online or on social media that said that hormones were a treatment for anxiety. So let's look carefully at what the science says about this. There have been well over 50 studies on the topic of menopause hormone therapy and depression and anxiety. But in terms of high quality studies, those studies that compare women receiving menopause hormone therapy and a control group or placebo group, there have been far fewer. there's only been 16 very well done studies that have looked specifically at the effects of menopause hormone therapy on anxiety. And what did they find? Well, 12 of those studies were of very high quality and also measured anxiety in a way that was valid and meaningful. There were some differences in the different studies in the type of menopause hormone therapy that was given, but in all of the trials that were done, there was an improvement in anxiety symptoms with menopause hormone therapy. But the authors of the review concluded that it may be because the menopause hormone therapy was helping other symptoms. Perhaps it was improving the hot flashes and night sweats, and that's why it improved the anxiety symptoms. So the take-home message is that while there is scientific evidence in favor of menopause hormone therapy for anxiety, it's currently not part of the Menopause Society guidelines as a primary treatment for anxiety. So why don't we take a pause there, Nicole, and let's hear some of the questions that were submitted.
Thanks so much, Dr. Brotto. I'm noticing a few themes with CBT, as well as the importance of information and education in both depression and anxiety. The first question that we'll move towards is it kind of points to the fact that while menopause itself is a distinct experience, that people experience it in different cultural ways and social ways. And this person in particular is asking for people who do experience shame, grief, and identity loss during menopause that might be related to anxiety, what supports might exist for them?
It's an excellent question. I think it highlights the fact that anxiety arises not just because of those hormone changes that happen in midlife, but it also can arise because of things happening in the person's environment, in their relationships, in how they interact with society. And so if those factors are felt or experienced as a stressor, then the brain's way of coping with that is to produce the anxiety response. The brain can't differentiate, is this stress from a societal belief, or is this stress from changes in estrogen that are happening in my brain? So it really is up to the individual to use this period of time. And, you know, as a registered psychologist, I'm a big advocate for particularly midlife women considering reaching out to a qualified mental health provider, either a registered psychologist, registered clinical counselor, perhaps a social worker, someone with skills in who has worked with midlife women to really address this. Sometimes what women have shared is that during this period of time, the midlife, that this is kind of an optimal time for them to address some of these facets of their life that maybe have been buried for a long time. So maybe there's grief or shame or identity issues that have been there for many, many years. But because they really want to get a handle on their health, their mental health and their physical health during the midlife, this may be a time for them to address all of that. So I can't emphasize enough how important it is to ask for help, to reach out to a qualified healthcare provider, and to create a space for addressing these things, because we do know that psychological treatment can be a very, very effective way for helping you have some symptoms and make some sense out of these experiences so that you can feel better.
Great answer. This person has shared kind of an experience. They have interacted with their family doctor, and they've said that they're finding it difficult to have their family doctor take them seriously about their anxiety during menopause. And they've been told to just go home and take some deep breaths. And while they know that deep breathing does work, it's not enough. Do you have any advice for them?
Yeah. Sadly, this is a common experience, and I think part of the problem is that we don't have universal education on menopause for our healthcare providers or our family doctors, and that's something that those of us in the field are working hard to change, to make sure that family doctors understand the range of 30 different symptoms of menopause and the fact that anxiety as I mentioned earlier, over half of women in the midlife period do experience clinical symptoms of anxiety. So that's the first thing, and that's not an answer that will benefit this woman in particular, but if there's any healthcare providers who are logging in, really important to increase and expand your own menopause education so that you know when to recognize anxiety. So I think what I would provide advice to this woman, or really to any person, again, as I mentioned earlier, is track your symptoms, track what does anxiety show up like for you. Is it that your heart is racing? Is it that you have racing thoughts and can't sleep? Is it that you have other physical signs and symptoms in your body, sweaty palms, dry mouth, difficulty concentrating, all of which can be symptoms of anxiety. And so tracking those things and being able to show that this is not just happening in response to, say, having a bad day at work, but rather these are quite persistent anxiety symptoms that are happening. And we want to be a bit of a broken record, so to speak. We want to reiterate those concerns over and over again. And I have a lot of confidence in the amount of education that I'm seeing in our healthcare providers, that we are seeing healthcare providers understand the full scope and spectrum of menopause symptoms so that women feel validated. So again, my advice here is to keep on, to track and to bring the symptoms to your healthcare provider.
Amazing. You mentioned work in your answer, and I think in the introduction you also described kind of the age range of when people do experience menopause, and because of that age range, many folks are actually in the paid labor force, and this question is specific to that kind of context. So this person mentions they feel really embarrassed talking to their coworkers and their boss about their anxiety, but it is interfering with their work. How should they handle the situation?
Oh, this is such a common one that comes up, Nicole. And, I certainly have heard firsthand from a lot of women who have said they're fearful of going to work because they're worried about having menopause-related symptoms on the workplace. And especially if it's, an important event happening at work or a talk that they have to give, they're really quite worried, and they're worried about losing the words. They're worried about having a hot flash during a talk. And that worry can actually contribute to them having anxiety and can increase the likelihood of them having all of those symptoms, the word finding problems, the attention problems, the vasomotor symptoms. Remember that graph I showed you earlier about the link between vasomotor symptoms and anxiety. So I think that's the first thing, is to recognize that when we worry about something, it actually increases the likelihood of us having symptoms. It becomes a little bit of a self-fulfilling prophecy, but it does that on a very kind of brain-related level in the body. So that's number one. And it also suggests that using some of those evidence-based strategies about reducing the stress system in the body, things like deep breathing, meditation, cognitive behavioral therapy, diaphragmatic breathing, all of which are quite accessible even through YouTube links, et cetera. And practicing those skills, say, before an anticipated stressful day at work is really important. Now, that's not necessarily going to change the work culture or the understanding of menopause at the workplace. And here's where I would actually advocate to women to maybe bring it up at a staff meeting or have a one-on-one conversation with their HR manager or their manager or employer. Because what we're seeing actually is that a lot of employers are very interested in delivering more menopause-related information, webinars like this, to their staff, not just to the midlife women, but to the entire workforce. So to men, to younger and older individuals, and everyone in between. And we can all benefit if we understand a bit more about menopause, because then we can understand how to support one another. So I guess what I'm conveying in this response is I really want to, number one, normalize this person's question. You're not alone. Your fear about bringing this up in the workplace is valid, and we understand why. And we're seeing changes, and maybe you can be that person to bring this up on the workplace so that others can benefit from it as well.
Absolutely. Thanks so much, Dr. Brotto.
Okay, we're going to chat now about our last of the three topics today in this webinar. And the topic is now sexual health. And as mentioned during the introduction, sexual health, and in particular sexual health in menopause, is an area where I spend a lot of time in both my clinical practice as well as my research and in my writing. And on this introductory slide, I'll give you a minute just to read and chuckle at the cartoon image, first of all. But what we know from work from the Menopause and Work in Canada study that came out in 2023, it asked women if they have any sexual symptom during the perimenopause, and half of them said yes. And in fact, 3/4 of them said that that these sexual changes had affected their quality of life by impacting their energy, their relationships, and being related to other health issues. I would guess that these numbers on the screen here is probably an underestimate because this study was focused much more on the impact of menopause symptoms on the workplace and wasn't a study specifically looking at sexual health and well-being in midlife women. Remember that graph that I showed you at the start of our discussion today that had all of the different colored lines and how those lines changed over time? And what you'll remember, hopefully, is the red line in that graph, which basically went straight up. It didn't come down over time like the other lines did. And that line reflected sexual and urogenital changes, which indicates that sexual symptoms that start during the perimenopause may continue and, in fact, may worsen over time into the postmenopause. This can often be a difficult or embarrassing or very sensitive symptom to talk about. And my hope during the remainder of our time today is that I equip you with some information about sexual health, some language to use, so that you can identify when sexual symptoms are bothersome for you and talk to your healthcare provider about it. So there have been many large studies that have been done that have looked at the kinds of sexual symptoms that women have during the menopause. And I'm going to focus on just two of the most common ones during my time with you today. The first one is low desire. This refers to not being interested in sexual activity or not being motivated to engage in sexual activity like perhaps you were in the past. And one of the largest studies of midlife women that looked at over 30,000 women across the menopause stages found that low sexual desire was the most prevalent or most common sexual concern for midlife women. These studies show that 30 to 40% of mid-aged women report low sexual desire and that it affects their quality of life. Having genitourinary symptoms, which is something that we're going to talk about in more detail in a few slides. So this is things like having pain with sexual activity or having urinary symptoms like a urinary tract infection can contribute to having even lower sexual desire. So it becomes really important that when we talk to women about low desire, that we also think about, is pain contributing? Is pain the reason that women have lost their desire? Interestingly, 61% of women in a large study said that their low motivation for sex or their avoidance of sex altogether was actually completely due to their fear that sex would hurt. And in the same study, the researchers interviewed the male partners of these women and asked them, were they comfortable talking about these symptoms with their female partners? And very interestingly, and I think that this might actually counter some of our common beliefs, but what it found was that the men were very comfortable, in fact, more comfortable than the women in talking about these symptoms and wanting to find a way to work together to overcome them. So what's really important to know, and I'll walk you through this slide in a moment, but it's important to know that not all sexual symptoms are bothersome for women. And that's why it's really important for us to think about and that your doctor asks you the extent to which these sexual symptoms create bother for you or create distress for you. In fact, what this very large research study shows, and this is what I'm going to point out on this graph, is that if we look at this second line, this solid line with the solid black circles, When we ask women if they have low desire and if they're distressed by them, you see the peak in this graph happen at about age 50 to 59, which captures that average age of menopause in North America. And then it gets less prevalent over time. In other words, the low desire becomes less distressing over time. It doesn't mean the low desire goes away. It means that it becomes less bothersome for women. So maybe it means that as women get older, they're finding ways to cope, or they're adjusting to the low desire. So that's really important to think, not just about low desire, but does this cause distress or bother or interference in my life in some way? So let's talk now about the second most common sexual symptom that women report during the perimenopause. And it's something called genitourinary syndrome of menopause. And I specifically put the more medical term on the screen because we're actually hearing a lot of people on social media and other places use this term GSM. And it's really helpful for understanding that GSM is actually comprised of 3 different sets of symptoms, all within this big umbrella. So the first set of symptoms are the genital symptoms, and it includes things like vaginal dryness, itching, irritation, maybe a burning feeling, and these can be quite interfering and bothersome for a lot of women. The second set of symptoms are the urinary symptoms, things like dysuria, which means pain while going pee or while urinating. It includes incontinence, which is when you leak a little bit of urine or pee involuntarily. And it can also include recurrent or often occurring urinary tract infections, or UTI for short. And the third set of symptoms that fall under this umbrella of GSM are the sexual ones. And this includes things like dyspareunia, which is the word we use for pain with sexual activity. It can include decreased lubrication and arousal, and it can also include bleeding after sexual activity. In the past, it used to be thought that there were just a few isolated vaginal changes that happen during perimenopause. But as a lot of research has happened, we now understand, and as you can see on this slide, there's quite a few different things that can happen in midlife women. And as I noted, they can continue over time. So how common are these symptoms in midlife women? It varies a bit across the studies, but the studies range anywhere from 13% of midlife women all the way up to 87% of midlife women. But we also know that it's underreported, and it's because women may be embarrassed to talk about and acknowledge these symptoms to their healthcare provider. And a lot of women, the research tells us, don't seek treatment for these GSM symptoms because they're embarrassed or shy, or they might falsely believe that this is a, quote, normal part of aging and nothing can be done about it. Healthcare providers sometimes hesitate to ask questions, especially about sexual health, or they might not be aware of the evidence-based treatments to manage the symptoms of GSM. But because GSM is a risk factor for other sexual concerns like low desire, difficulties with orgasm, low satisfaction, it becomes really, really important that women and their healthcare providers understand the symptoms of GSM and then talk about it. So you might be wondering, what are the causes of these sexual changes, whether it's the GSM symptoms that I just talked about or the low desire symptoms that I just talked about. And of course, we have to consider the role of the menopause-related hormones. So first of all, those escalating and de-escalating levels of the ups and downs of estrogen and progesterone, and then the eventual decline in those hormones can contribute to pain and dryness of the vagina, which in turn can impact sexual desire. But it's also really important that we recognize all of the other psychological and social changes that are happening in this phase of a woman's life that can directly contribute to her sexual health. So when we look at this list of the psychological factors, this big blue bubble on the lower half side of your screen, you can see that a woman's past sexual health, her past sexual function, her current levels of stress, her feelings about her body, and her energy levels can all affect her sexual health during menopause. As one example, we have seen this in research over and over, is that women with a history of childhood sexual abuse or neglect are less likely to be sexually active and to have more menopause symptom burden, as well as more sexual problems during this phase of life. And this is an example of how aspects of a woman's history might interact with those hormone changes of perimenopause to then lead to sexual symptoms during this period of time. Then we can also consider some of the social factors, and that's this bottom right blue bubble. And this would be things like impact of race and culture, religion. Is there a partner involved? Is there a change in partner status? Has a partner passed away? Has there been a separation or divorce? Is the woman caregiving for children and elderly, and maybe two sets of elderly on both sides, but also her feelings for her partner and her relationship? In one study that was done, a very large and famous study called the Study of Women's Health Across the Nation, which was a large study of American Black women, Asian women, Latina women, and white women, what they found was that Black women experienced more severe and long-lasting symptoms than the other groups, whereas the Asian women tended to have fewer symptoms and had symptoms later on. And this, again, is an example of how race or ethnicity can interact with some of those hormone changes to impact the symptoms that you experience. So the important take-home message on this slide is that if you are someone who is experiencing sexual difficulties, to really take a step back and think about what aspects of my background, my psychology, my social environment, my relationship, in addition to my hormones, that can be contributing to the sexual concerns that I'm having. Another thing for us to think about when we think about midlife sexual health is we're aging at the same time. And we know that aging can directly contribute to sexual changes. And the answer from the research is that both are happening. Both age and menopause can contribute. But there's also really strong evidence that even in this period of aging and menopause, that some factors like having a partner, seeing sex as something that's important to you, having well-managed mood symptoms, and having a positive attitude to aging can actually buffer against some of those symptoms on sexual health. And so sexuality remains important to women across the menopause transition, and having a positive outlook to sexuality actually leads those women to have more sexual satisfaction in the long term. So that's really important. I don't want to just lightly gloss over that because as we mentioned when we discussed CBT for depression and anxiety, sometimes challenging and changing specific beliefs that we have about aging as signaling the end or menopause signaling the end of a sex life, changing and challenging those can actually very significantly improve sexual health and well-being. So in our remaining time together, I want to talk about some of the evidence-based treatments to address sexual health. And I'm going to have a lot of information on the slides, but I'm going to focus on just a few highlights in our remaining time so that we can have time for a couple of questions before we wrap up today. So first of all, having education, and this is something you've heard me now say a number of times in this webinar, having access to good quality education by healthcare providers with expertise in menopause and sexual health is critical. And we need to be careful about where we're obtaining our sources of information. And while social media can be excellent and very accessible, we do need to be a little bit careful about scrutinizing the information because not all of it is based on science. So there's very strong evidence for counseling, sexual aids, and then I'll talk a little bit about some of the medications that are used, although not necessarily approved in North America as a treatment for sexual dysfunction in the menopause. The point is, and this is what this bottom graphic tells us, is that personalizing treatment to you is critical, so that we know that the treatment we're delivering to you takes into account who you are, your history, your relationship, your well-being, and other facets of your health. So in terms of counseling, this can be as kind of light as managing stress, all the way through to psychological treatments like cognitive behavioral therapy and mindfulness-based treatments. And so CBT and menopause actually has a lot of very solid evidence in favor of improving sexual symptoms in menopause. And we talked earlier about what CBT involves. It involves targeting problematic thoughts as a way of improving behavior, as well as improving our emotions and our body's physiology. We also target avoidance. So if you're a woman who's now avoiding all forms of intimacy because you're afraid of sexual pain or low desire, we can also target that in the context of CBT. And as I mentioned, lots of very solid evidence in favor of CBT for sexual concerns in menopause. Mindfulness has also been the subject of a lot of research, and in full disclosure, this has been a lot of my research as well, that has actually tested mindfulness against a control group and found that mindfulness can be very effective for improving low desire as well as pain with sexual activity in women. There's been a bit less research that's focused specifically on midlife women, but the research that has been done has also been very promising. And I noted earlier that mindfulness can be accessible through apps and through workbooks, and also that when women learn these skills, they're quite motivated to continue practicing these skills in the long term. Very briefly, and I think this might be the topic of a future webinar, it's important to know that a lot of physical aids can and should be considered as well, especially if there's pain or discomfort in this period of time. So ensuring that you are using a lubricant during every sexual encounter. And this is different from a moisturizer. A moisturizer tends to be used inside the vagina to make sex less painful. Vaginal dilators are often used in the context of pelvic floor physiotherapy and can be a staple of treatment for those midlife women who are also having pain during sexual activity. And so seeing a pelvic floor physiotherapist is often something we highly recommend. What about those lifestyle interventions that we talked about earlier? Exercise, well-being, reducing alcohol. There's actually been some evidence that a multimodal treatment, a treatment that lasts 12 weeks long, that includes all of these components, exercise, good eating, drinking water, limiting alcohol, can improve sexual well-being and satisfaction in the midlife. What about those hormones? And with the caveat that I'm not a gynecologist nor a prescriber, what I'll share with you very briefly is some of the evidence-based guidelines, and that is that vaginal estrogen delivered to the vagina through a cream, through a pill, through a ring, is part of the guidelines as part of the treatment for the genitourinary syndrome of menopause. And in terms of those systemic hormones that are taken by mouth or through a patch, we know that the studies have shown that there's no direct effect on sexual desire. A large meta-analysis, which is a review of many studies, found that compared with a control group, estrogen therapy or estrogen plus progesterone therapy resulted in no effect to a small benefit on sexual function. And we know that any effect of menopausal hormone therapy on sexual function is likely due to its effects on reducing pain. We'll now talk very briefly about testosterone therapy because it's been getting a lot of attention in social media. Right now, testosterone therapy is not approved by the FDA or Health Canada in women, but in 4 other countries around the world, it is approved for the treatment of low desire in postmenopausal women. There have been a number of studies showing that testosterone therapy in postmenopausal women can improve sexual desire. And if this is something you are interested in speaking with a healthcare provider about, please keep in mind that it is not FDA or Health Canada approved. So that brings us to the end of this segment, and we probably have 1 minute or so left for a question or two, Nicole.
Thanks so much, Dr. Brotto. As you can imagine, sexual health was one of the most popular question topics. You have covered quite a few of the questions, though. Lots of folks interested in non-medical options for managing sexual health and staying well during menopause related to their sexual health. Perhaps given your own area of research and practice, the earlier on in the sexual health presentation, you talked about partner relationships. Do you mind taking this one person's question, which is, how can couples openly and respectfully communicate about changes in libido during menopause?
Yeah, it's such an important topic. I mean, first of all, let me acknowledge that you don't need to be in a relationship to have sexual changes. So those sexual changes can affect you whether you're with a partner or not. But, one of the ways that I often encourage women to do so is by referencing a webinar like this. So you might say to a partner, I watched a really great webinar that was focused on sexual health. And what it found was that feelings for a partner and ability to talk about sex over time is actually a very significant factor that predicts those couples that will be sexually satisfied in the long term. And I know we haven't talked about this topic today, but given that I am in the perimenopause transition, I think that I would love for us to talk about this. So that's one way. You can reference a webinar like this. You can also bring it up through other indirect routes. So talking maybe about stress or mood or depression, and then from there talk about, and I've also noticed that when I'm feeling really anxious, it affects my desire for sexual activity. And I read somewhere that this is really common for women in my stage of life or in my age. Can we talk about this? I always recommend setting time aside to have this conversation, not having it during, sexual activity, not talking about it in the bedroom, but treating it as a really important topic of conversation, just as you would other really important aspects of your life and well-being.
Yeah. Great answer. I think that's all we have time for today. Thank you so much, Dr. Brotto.
Thank you. Thank you to those of you who tuned in today, and I hope that this information was very useful for you. And I think, I also want to emphasize that you have hope, that we have excellent research evidence in favor of a variety of different treatments, that you don't feel like you have to suffer in silence, and that you feel like you can be your own best advocate to ensure that you age well in this period of your life. So thanks again for tuning in today.